Good morning, everyone. I think this audience probably has a pretty fair sense of the context here in terms of the role HHC plays, but just for the handful of you that might not, it is the largest municipal healthcare system in the country. We have 11 acute care hospitals, 4 long-term care facilities, more than 70 ambulatory care sites, serve 1.4 million New Yorkers every year. 1/3 of them are uninsured, about 5 million ambulatory care visits a year, more than 1 million ED visits, run 6 level 1 trauma centers, deliver about 20% of the babies in New York, 23,000 deliveries a year. So a very important part of the city's healthcare infrastructure. And then the context for our IT environment, which is vast and complex. We have almost 35,000 PCs, laptops, workstations, some 2,000 databases, run more than 900 applications, some 450 interfaces. And we have stored about 2.2 petabytes of data. So for those of you like me who are not sufficiently geeky to actually know what a petabyte is before I'm told about it. So a petabyte is 1,000 terabytes. 10 terabytes would be sufficient to hold all the data in the US Library of Congress. So we have been using electronic medical record for a long time. We have a lot of aggregated data, and obviously it's critically important to protect that. Before I focus briefly on that, it probably would be a good idea just to talk more generally about the response to Superstorm Sandy and where we now are. Let me preface by saying that the city and HHC really do have robust emergency preparedness plans and capabilities and a strong, well-defined incident command structure, both locally and enterprise-wide for HHC and through the Office of Emergency Management. Through the city, we actually do have a representative at the city's command center as well throughout the time that it is open for any emergency. All of that was activated well in advance of Sandy hitting the city. And obviously, we did everything that all of you do in your institutions in testing and tapping generators and laying in more supplies of food, and general medical supplies and having cots at the ready and bringing on more staff. And it's good that we did all that because Sandy hit our public system very hard. At one point in the immediate aftermath, we had 7 facilities on emergency power. As you all know, 2 of our facilities were damaged significantly to the extent that we had to evacuate patients in the aftermath. We had 1 community health center that has probably been destroyed beyond restoration in the Coney Island section of Brooklyn. And we have 1 long-term care facility that lost all power for a protracted period of time and today is functioning on emergency systems for power, for heat, and for hot water. And will continue to do so for at least the next couple of weeks. On the issue of evacuation, obviously this time there were not mandatory evacuations from the lowest lying flood zones. Zone A, we do have 1 facility in the periphery of Zone A in Brooklyn, that is Coney Island Hospital. It was evacuated for Hurricane Irene, and those patients were evacuated safely. Hurricane Irene did not come close to endangering any of our facilities. We didn't take water in anywhere. That said, it is not an easy decision to evacuate a hospital. There are significant risks of evacuation, even under the best of circumstances, particularly for critically ill patients. As a precaution at Coney Island, although there was not a mandatory evacuation, we did transfer 20 ventilator patients who were quite stable. We did not evacuate an additional 12 who we considered to be less stable, but this did allow us to feel that in the event of the worst, We had more backup battery packs for those ventilators. We had a good ratio of respiratory therapists and other staff who could actually ambu bag and otherwise manually ventilate if that became necessary. I was at Coney Island Hospital at the night of the storm in their command center. And Coney had never seen water come anywhere close to the hospital. And obviously on that night, for the first time, water surrounded the hospital. It was perhaps 3 feet deep in parts of the parking lot. It entered the first floor of the hospital. One indelible image was after we lost power, because the emergency generators there actually are just above grade, 2 feet above grade, and our engineers smartly powered them down before the water hit them and shorted them out. But for 4 hours, we were without power and using flashlights and the battery-powered light. And the executive director and I went down to the first floor just to check out the first floor, which at that point had been evacuated. There was a knocking on the front door of the hospital. We pried open the electric doors. There were flashlights on the other side. There were 3 emergency rescue officers with a raft, 3 adults and 2 dogs in the raft, and they floated into the first floor of Coney Island Hospital. So it's not an image I will soon forget. We were able, after about 4 hours, to restart the emergency generators, and so we had power back up. During that period, the patients on ventilator were on backup battery power. Once the elevators were then powered up, obviously we began the process of evacuating about 200 patients. We had reduced the census there in preparation for the storm. There were no elective admissions. There were some early discharges before the storm. The scenario at Bellevue was similar yet different. Bellevue not only lost Con Ed power, it also lost heat and hot water because it is one of the facilities in Lower Manhattan that is fed by the steam grid from the cogeneration plant that Con Ed runs, and those grids were shut down. Both Coney Island and Bellevue, we believe, could have withstood storm surges of up to 12 feet. The National Hurricane Center, about 48 hours before we began to feel the brunt of the storm, was predicting storm surges of 4 to 8 feet. That's the window for evacuation, really. You need really to safely evacuate patients. The logistics are pretty complicated. You have to start that process, though, later than 48 hours before you expect bad conditions. So that window was closing at that point. About 16 hours later, that prediction was elevated to 6 to 11 feet storm surges, but the probability models that the center was putting out said the probability was 5 to 10% at the high end in the areas that would affect our hospitals. That obviously turned out to be inaccurate. That's not a criticism of the National Hurricane Center. I think they do a great job. But in fact, the probability models, I think, just weren't designed for this freakish storm, which included a whole number of factors. Usually storms coming up the Atlantic in the winter or in late October, the waters are colder, they diminish in force. For whatever reason, the temperatures of the water were 2 to 3 degrees warmer than usual. Usually hurricanes get pushed out to the east by the prevailing westerly wind. There was a ridge of high pressure over Greenland that blocked it and pushed it in. There was a confluence of a front from the north and a front from the west that was converging just as it was making landfall, and so it accentuated the pinwheel motion of the storm. So it is estimated, based upon readings at Battery Park, we don't know the exact readings at the locations of Bellevue and Coney, but at Battery Park, it was nearly a 14-foot storm surge. So that inundated the basement at Bellevue Hospital. When I say inundated, it came in like a mini tsunami. There is a large loading dock there, and it just barreled in with so much force that it knocked elevator doors off their moorings. And in some instances, even parts of the system that had been protected. After Hurricane Irene, it occurred to us that the fuel pump, which brought fuel up to 4 major emergency generators on the 13th floor, was vulnerable because it was below grade. It was enclosed in a watertight compartment with what's called a submarine door, which has 7 pressure levers and a rubber gasket. It kept that pump dry. However, the sheer force of that raging water going through tunnels and space that there's 180,000 square feet of space in the basement complex under Bellevue. It is enormous. And the force of that water clearly just dislodged some of the electrical conduits coming down from the emergency generators to those fuel pumps. So we lost the fuel pumps. It helps to have very dedicated, ingenious staff in emergencies like this when the unexpected happen. After a while, it occurred to staff that they only had 7 hours of fuel left on the 13th floor for those 4 big generators, and they came up with a bucket brigade up 13 flights of stairs in order to carry up 5-gallon containers of fuel to continually top off the reservoir at the top. I don't think everybody realizes that emergency generators, particularly in a complex as big as Bellevue, doesn't provide full power. About 30% of the normal power was being provided to the Bellevue complex. It's enough to run all of the life support and life safety systems, as well as the elevators, except that the elevator shafts of all 32 elevators were completely flooded with several feet of water. None of them were operable. Other essential systems were damaged and failed, including the water pump that fed the water tank at the top of the 18-story building, meaning that once that tank was depleted, water pressure would be lost. That happened about 36 hours later. Once it was clear we could not recover even one of the elevators for the transport of patients out of the building, we began an evacuation that essentially came down the stairs. And so there were 715 patients at Bellevue when the storm hit. All but 2 were evacuated by Thursday morning. The National Guard was absolutely spectacular. They provided the muscle to actually bring these patients down the stairs, as much as 18 flights. 2 patients remained and were not evacuated until 72 hours later, when we did get one of the elevators operating. One of the patients weighed 600 pounds and could not be safely brought down the stairs, and the other had just undergone cardiac surgery and was unstable. Both of those patients ultimately were safely transferred to other facilities, and we're grateful for the incredible support we got from EMS, from the National Guard, from so many of your institutions in helping to coordinate that very complex evacuation and transfer of patients. As I said, Kohler Goldwater, a skilled nursing facility, it was without power, heat, and hot water for a protracted period. It's been brought back up on emergency systems. It has 550 residents who sheltered in place and are fine. But there has been extensive mechanical and electrical damage at all 3 of these facilities. Bellevue, perhaps the worst damaged and the most complex facility, and therefore, as you can imagine, with 180,000 square feet of space down in the basement, there was a lot of stuff down there and a lot of important systems for heat, for domestic water, IT switches, communication switches, PBXs, lots of power distribution panels for the older parts of the campus, the newer buildings, including the ambulatory care pavilion. Actually, those panels were brought above grade. It's going to be a while coming back. We actually, at Coney Island, began ambulatory care services 3 days after that storm in the newer part of that complex there. That's being provided 24/7, principally primary care service and behavioral health outpatient services as well. At Bellevue, we will bring up similar services on a 24/7 basis this coming Monday. We're working hard on the EDs for both of those institutions and hope to have them both in operation by the end of this month. That doesn't necessarily mean full operation, particularly at Bellevue, which will not function initially as a level 1 trauma center for emergency cases. Both will require waivers from the state health department because, for example, Bellevue will have to operate its ED on emergency power for some additional protracted period of time. We will, of course, have backup generators for the emergency generators that will provide primary power. Bringing the entire hospitals up, including the critical care units, the ORs, the inpatient units, will take about 2 months at Coney and about 3 months at Bellevue. That's the first week of January for Coney, first week of February for Bellevue. And then just to talk very briefly about the technology side here, since that's what this summit is about. We managed to keep all of our mission critical systems pretty much up and running. We lost the EMR at Coney Island only during the time we were out of power completely. It came back up. When the power came back up at Bellevue, we did shut it down at one point because we had a 5th generator that we actually rediverted. It was on the first floor to the critical care area when we were concerned about the fuel situation for the emergency generators up on the higher floor. That generator powered some of the network switches. We got instability in the EMR. We shut it down. But throughout, we had an EMR station operating for chart review and printing at the command center during the evacuations. The things that served us well in terms of our IT continuity, business continuity plan, we run 2 redundant data centers with most of our important applications and all of our mission critical applications being fully replicated and synchronized in both. We run them both hot. So we balance the application loads to both centers continuously so we don't have the lag time of bringing up a cold backup data center. That was fortunate because one of our data centers in the North Bronx, another one is in the SunGuard site at Carlstadt, New Jersey, about 25 miles apart. Ironically, Carlstadt, which is not in a flood zone, a berm on a river 3 towns north was breached and water flowed through those northern towns into Carlstadt. At one point, there was 4 feet of water in a portion of the parking lot by the Carlstadt SunGuard site. And at that point, we switched all of the system applications over to the Jacoby site in the North Bronx. It was seamless to the users, and at the end, the SunGuard site was not actually compromised, and later on, we went back to balancing the load. We made an early declaration of business continuity necessity at the SunGuard site. We don't pay to reserve workstations there, but we have an option, sort of first come, first served, on 80 workstations. And we declared that early enough to actually get 80 workstations, so we had IT folks there in fully equipped workstations. We had redundancy in our wide area networks that proved very important. We actually maintained them with 2 carriers, LightPath and Verizon, with sensors to do auto switching if there is disturbance in one or the other, which there was. And during this period of time, we did flip back and forth between the 2 carriers, but that also was seamless to our users. And then finally, we have a large enterprise service desk call center that was located at Bellevue that takes 38,000 service calls a month, and during prime time has some 42 staff there. Those staff had to be relocated to 10 different locations, but because the call center functions essentially on a cloud-based, server and applications, they were able to do that from their disjointed locations as if they were running one call center, and again, that was seamless to our users. So I just want to mention that Bert Robles is here, a corporate CIO, who's actually the brains behind all this. When you hear me say anything related to IT, my lips are moving, but he's throwing his voice. But he and his team did a fabulous job for us on this front. So 2 final observations of lessons learned Obviously, redundancy, 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 and in communications in particular, it was critical that we maintain communications internally within these facilities, particularly the ones that had to be evacuated, and externally. The coordination required to doing evacuations is very complex. We had, and we used them all, we had analog phone lines, we had voice over IP, we had a stash of cell phones with multiple carriers. At times we used texting, and we had 800 megahertz two-way radios. And at various points in the storm, we used them all, because as you know, there were failures among many of the carriers, and there were all kinds of other issues that otherwise impeded communication and made it difficult. Lastly, I would just say that having dedicated and ingenious staff who are really committed to keeping your patients safe really goes a long way in helping you through a crisis with a magnitude as unanticipated as this one is. I'm very proud of how our HHC personnel and many of the other personnel, both in your systems and across the city, how well they work together and how hard they worked and what long hours they worked in such a dedicated way. But obviously, we owe it to them and we owe it to our patients to actually take seriously the lessons learned here. This is an event that hasn't occurred in New York City, I gather, for 190 years. The last time we had a storm surge, anything remotely like this recorded, is in 1821. And we're going to go forward assuming that this can happen again next year when we hit the next hurricane season, and that's going to require an enormous amount of work to reposition systems and to harden our facilities to make sure that we can get through this the next time without going through as much turmoil as we have this time. Let me stop there and take any questions you may have.
Thank you. Do you have a sense of what the total damage is? What the bill is going to be?
What the price tag is? You know, that's
where are you going to find the money?
Well, yesterday the mayor and the city council announced that there is going to be a capital appropriation imminently of $500 million. $200 million of that is to meet the capital needs of the school system that was significantly damaged in part. $300 million is for our public hospital system. Whether that's the ultimate number, I don't really know, because we are completely focused on getting these hospitals up and running again as quickly as possible. That means that there will be limited opportunity to address some of the repositioning issues that are involved here that are really quite complicated. And we're going to have to do some of that at a later point, yet we're going to have to do that with urgency once we get past this initial challenge of getting the hospitals up and running. It will be expensive to replace, not just to replace, but to reposition these systems in facilities that you're running 24/7 and can't just shut down while you're doing the work. But that price tag is likely to be north of $300 million. Obviously, FEMA, a lot of this is FEMA reimbursable. I understand that Senators Schumer and Gillibrand are both working on getting a congressional appropriation together with their colleagues to help the storm-ravaged areas, to fill in some of that gap, that FEMA gap between 75% and 100%. There's also significant revenue loss here. There's an 1135 waiver that has been submitted to the federal government to try and cover at least a modest portion of that, but it is an expensive proposition, and the costs here are quite enormous.